You are listening to the Social Worker Radio Show. My name is Luke. I am the man in charge of the board. I'm here with Catherine Zox and
Alyssa Lotmore.
And he is the man in charge of the board. I'm Catherine Zox. You are listening to the Social Workers Radio Talk Show on WCDB FM, University at Albany. And Alyssa's my co-host here. How you doing this morning?
Great.
Good. Me too. We have a guest this morning who's going to be calling in. I think he's going to call in probably around 9:15, and is going to be talking about Obamacare, or the Affordable Health Care Act. I really don't like it when they say, for some reason, Obamacare, because it sort of, to me, dismisses it. It is the Affordable Health Care Act. I
think it was originally created by that term by the Republicans during the election as a way to sort of a negative way to describe it, and it sort of caught on even amongst Democrats and even those who supported it. So I still try to call it the Affordable Health Care Act.
So I knew we were going to interview, it's Dr., let's see, what's his name? Dr. Peter Anderson. He's also an author. His book is called The Familiar Physician, and he has what he calls the Family Team Care Model, which he founded, which is a major organization, I guess, to help physicians and healthcare practices be more, I guess, what's the word, able to provide their services in a way that's better for patients and also for physicians. There's a word I'm trying to think of. What would you say? Doing it in a way that's, he has the physicians, the nurses, all the participating healthcare professionals in the family care team to provide services for families and for individuals, rather than just the doctor and the patient.
Well, I think it's important to have that feel with the other providers, because sometimes the doctor isn't available, and to have a relationship with the other people in the office and with other healthcare professionals is more comfortable to the patient.
It is. I have so many questions for him. I really, I think you and I talked last night. We have master's degrees, both of us, and we don't understand what the Affordable Care Act is. And if you interview people on the street, and I think it was Jay Leno or one of those talk show hosts, they were interviewing people on the street, what do you think about Obamacare or the Affordable Health Care Act? And they, first of all, had no idea what it was. They had an opinion, but not an opinion that you want to really put into practice. So it's 2,700 pages, I think, of legal stuff and the act itself. So maybe Dr. Anderson can clarify it for us. Do you know what it is, Luke?
only a little bit.
Well, what's only a little bit? What do you know?
Well, I'm going to talk about my experience with healthcare at this point in time.
All right, go ahead.
So I have health insurance through the school, and every time I go to file a claim, the claim gets bounced back because they say your health insurance requires more information. And I call up my health insurance, and they're always like, oh, we're just calling to see if you have other health insurance. And I'm dealing with a claim right now that, I was referred to a specialist by the people at the health center, and I was like, this should go smoothly. And I'm like, it's a charge dating back to August, and I feel like I've had, several claims, and it's always like, they're always like, oh, do you have other health insurance? And I haven't had other health insurance for the 3 years that I've had your health insurance. You would have think they would have made a note about it by now. And
this happens every single time?
Yep.
What do you say to them? Write it down? I mean, I come in here, but they don't.
No, they don't.
So that's inefficiency.
Yes.
Okay.
And so that's kind of the issue that I have, and I see, I want to blame the Affordable Care Act for that, just because it seems like one of the stipulations I know that was included in it is that you are allowed to be on your parents' health insurance for a longer period of time.
Till you're age 26.
Right.
I think.
And so they're assuming it's oh, now that this has gone into play, maybe they're back on their parents' health insurance, but I'm not going to give you extra money for more health insurance because I know at least it used to be illegal to be covered by multiple health insurances, or there was some issue with that. So
you can be covered because I mean, I had double coverage, but
Okay.
what they do, one has to be the primary
Okay.
one, which they go to first, and
Right.
let's say for whatever reasons it only covers so much, then they go to the secondary one. But the thing is so complicated, and something that you just said struck me. You're fighting a battle. First, you're fighting a battle with whatever disease you have, and who, or mental, physical, or both, and then you have to fight a battle to get reimbursed. It doesn't seem to me that that's really a good way to provide health care. Does it?
No.
There's so many different ways to try to navigate the system. Even when I had my daughter, I had to call health insurance. I had to get approval from this. I had to make sure this signed off and I'd be reimbursed. So it was an extra stress that I didn't really feel like dealing with. And I even know before my daughter was born, I was calling up to make sure, what do I need to have in place? What do I need to do? I had to spend numerous hours on the phone just with representatives to making sure I had my documents in order, because that's a huge bill if something goes wrong along the way. So it's definitely something I hope gets smoothed out, because it's causing stress to the population.
And it's a stress when you're stressed out already, like you said. I mean, you just give birth to your daughter, which should be a happy time, and you've got all this stuff you have to handle. And the other side of it is, I was listening to Howard Stern yesterday, and he was talking to Robin, his co-host, and Robin had uterine cancer, a very serious uterine cancer, and it involved lots of surgeries and just a whole lot of stuff. And Howard, I guess, was the person who was the instrumental person in, he said, setting up a team, I mean, literally, to find out the best doctors, the best nurses, all about her care. But it was a whole system that he created in order to expedite Robin's care and surgery and aftercare and all that kind of stuff. So, I mean, that's another example. And, of course, she's stressed out. I mean, this is a catastrophic illness. This is really something that could be terminal. And so, talk about being under stress, and if you don't have Howard doing it for you, or a Howard, then and family members are often just as stressed out as you are. So, I mean, that's another piece of it. That doesn't work.
And I mean, even to sort of express it a little more how stressful, even when I was in labor, I was going up to the hospital. They asked me for my insurance card. I had to stop, sign some digital paperwork on their tablet. While I'm in labor, I'm like, can I please sit down? And they're like, can you just sign these few forms first for insurance purposes? So even then, it's still, insurance is primary over the medical care. They want to make sure that you have that paperwork, that insurance coverage. They had to scan my card. It wouldn't scan. They had to scan it again as I'm sitting there
with contractions,
taking my deep breaths, trying to, sign paperwork and wait till my insurance cards scan through their system again so they can confirm it's me.
I had a similar experience. I don't know, and you guys probably have never had a kidney stone, but it's because it's as painful, short term, but still as painful as having a baby, and it's excruciating. So I had my boyfriend take me to the hospital. I'm in excruciating pain. I can barely move. Brings me into the emergency room. The admitting thing, what you have to do, what you have to tell them what's bothering you. I was in such pain, and she's doing the same thing that she did to you when you were in labor, the admitting nurse or administrator, whoever it was. What's your insurance card? I dropped to the floor, and I said, I can't tell you anything until I get some painkiller, I get taken care of. I cannot I literally sat on the floor. I said, I can't do this. But the patient wasn't really the main concern. It was the insurance. That's not a good way to practice medicine.
It isn't. And I'm interested because I'm always interested in comparing Canada's insurance process to the United States. When I'm trying to learn a little bit more, I know the Albany Public Library on November 20th is having a screening and a panel discussion of the healthcare movie, it's called, and it compares Canada's insurance healthcare process in the United States. But I'm interested to see, they've been using theirs for a very long time. What are the positives and negatives? Can we learn something from how they're doing it? Is there things that we should change in ours? So I'm kind of interested in learning a little bit more about that and the different around the whole world, what their healthcare policies are, because it just seems like the United States isn't getting some things right, and I'm kind of hoping that we can have a guide.
Well, we were in Rome this summer, and we were traveling around, and we had a guide, and she was in her early 30s, and we were talking about healthcare, and I asked her what the healthcare system is like in Rome, and she said everybody gets healthcare. It's not a problem. It's good. She was a PhD, an archaeologist, she said, "What's it like in the United States?" I couldn't describe it. She said, "Does everybody get healthcare?" And I said, "Are they entitled to it?" And I said, "Not really. I guess, there are 30 million people who are uninsured." She was baffled. She was so
considered
surprised.
A responsibility.
Yes, yeah. It's considered a privilege, right? Instead of we are entitled to it. I mean, a healthy nation has to have healthy people and healthy children. But I couldn't explain it to her. She was totally, as I said, you don't have health care, just what do you do if everybody doesn't have health care? So that was very difficult to explain.
It's concerning. It's concerning that here it's considered, because I remember when I was watching one of the presidential debates back in 2008, John McCain had said, no, health care is a responsibility of the people. It's not a right. It's not a basic right. So when there's an economy that's sort of falling apart, and people are out of jobs, they can't afford basic necessities, and now you're expecting them to pay. The Affordable Care Act is less expensive than if you're buying it from the provider directly, but it's still a $600 commitment for family coverage that if you're unemployed or struggling, that's still a lot of money every month to pay. So even then, how affordable is the Affordable Care Act?
Another issue is we are such a large country. What's our population now?
350 million?
And so I think it's about 350 million people. So when you're talking about other countries, and perhaps even European countries, they're much smaller. You're dealing with, 10 million people or 20 million people, So the economies are different. Canada, I don't know how you compare it. That's socialized medicine. Well, I know somebody, a friend of mine, who wanted to have, that surgery they do that glaze on your eyes. Yeah. So here, I don't know, the surgery was, let's say, and I'm kind of making up this number, but let's say $500 or $600, $700. She went up to McGill in Canada and had it done for $100.
3 people in my family went in Canada to get it done right when it first started coming up, because they were practicing it longer.
Yeah.
So I had 3 people in my family go up to Canada. It was 10 years ago, and they loved it.
Yeah.
It was less expensive, and they had doctors who were practicing for longer because it was more popular there before it came here.
Yeah. Well, that was exactly, she too, I think, was like 10 years ago. And of course, McGill University is one of the best universities in the world. So, so there's a whole lot of stuff that, we have to ask Dr. Anderson.
Well, even other countries, though, it seems like the United States is having more of a problem with health problems, the obesity rate and the smoking rate. Other countries have healthier lifestyles, it seems, whereas the United States is sort of, the statistics aren't as good for their actual health. So I'm interested to see how that plays an effect of other countries in their free health care. But do they have healthier people? Do they have healthier lifestyles? What is the comparison?
And maybe it's both. They have healthier lifestyles and healthier people and a healthier healthcare system. So it kind of all works in tandem. It works together. I don't think that necessarily we have a healthy lifestyle. Do you? We've stopped, that whole smoking campaign worked, and it's still, this is just anecdotal. It seems to me we smoke less as a country than, I travel a lot, and like in Europe and other places, it seems like they do smoke more than we do. It's more acceptable to be a smoker, and people don't mind sniffing in the secondhand smoke. I'm an ex-smoker, so, but here we still kind of resist smoking, although I see with teenagers, it seems to me that I see more of them smoking, and maybe even college kids. So I don't know if it's on the rise or not, but that's obviously not healthy.
There's so many just lifestyle changes, and I wish the insurance companies would pay more for preventative care. The Affordable Care Act is doing free no co-payments for some preventative services, but I'd like to see more doctors.
Like what? So no co-payment, you're saying?
You don't, for one visit, I think one well visit to your doctor, your primary care physician, there's no copay. For females, the female well visit, that is no copay for that. They're offering some more of the preventative services for no copays, which is really good. But how much really are we doing for more of the preventative services? There's no money in preventing. I was reading another thing. There's no money in preventing, cancer. The money's in, providing the treatment, the drugs that you need. That's where the money is. So doctors aren't getting paid to sit and talk about preventative. They're getting paid to prescribe things and to get tests done. So how can we balance that out where we're doing the more of the preventative work?
Well, that's Western medicine. Prevention isn't sexy either. It's much sexier that somebody gets really sick and you save their lives either through surgery or, medical treatment. It's sexy. I mean, House, you watch that on television, all these medical shows. But prevention isn't. And prevention is something that I think it was in China. They rewarded doctors for having healthy patients without, if their patients didn't get sick, if they didn't have to do all the testing, if they didn't have to do surgeries. I'm not sure how they measured it, but that physicians were rewarded monetarily for having healthy patients. So that's a very different approach.
A really great thing. I mean, every time I usually would go to the doctor before, whether it was something, something minor for me, they would always want to prescribe a pill or some sort of thing that I could get tested, and there was no need for it. I was fine without it. It was just like little things, but there was always some sort of, here, I can write a script as like proof that I helped serve you. So it's just an interesting method.
And then the doctors will say that the patients want the tests, and so then they sometimes blame the patient. Well, if I don't give them the test or I don't give them the medication, then they'll be disappointed.
Yeah.
And so
the liability thing, doctors feel,
afraid of
did I not test and I should have tested? So it's always that sort of that fear of, okay, do I not do this and I should, or should I do this and get in trouble?
Right. I think Dr. Anderson is on the line, so we'll take a short break, and then we get to talk to him and ask all these questions. You're listening to WCDB FM, University at Albany, the Social Workers Radio talk show with Catherine Zox and Alyssa Lotmore.
So you take the mouse and click over there, and then you can choose someone you want to call.
My niece. I click here?
Uh-huh.
This is Louisa. Recently she got help going online to chat with her family back home.
Okay, so then you want to hit that green button.
This is her first time on the internet and her first time seeing her niece in 5 years. Louisa doesn't know what to expect.
Louisa? Oh my gosh, there she is. This is amazing.
It's so good to see you. You look so pretty.
But this is definitely way beyond.
Oh my gosh.
See what the internet can help you do at everyoneon.org or call 1-855-387-9166 to find a free training class near you. That's 1-855-387-9166.
Oh, I've missed you.
Oh, me too.
Brought to you by Connect to Compete and the Ad Council.
We're back. I'm Catherine Zox, your social worker with a microphone. You're listening to the Social Workers Radio talk show on WCDB FM, University at Albany. And joining us this morning is Dr. Anderson. Do we have Dr. Peter Anderson on?
Yeah.
How are you this morning? Dr. Anderson is a family care physician. He's author of The Family Physician, Saving Your Doctor in the era of Obamacare. And also, Dr. Anderson founded Family Team Care Model. So, Dr. Anderson, we've been talking a lot about Obamacare. I like to call it the Affordable Care Act. And I'm Catherine Zox, but I'm also here with my co-host, Alyssa Lotmore, and she's an MSW as well, graduated from the School of Social Welfare a few years ago. So we'll both be asking you questions, but somehow the Affordable Care Act seems a little bit more serious than Obamacare. That kind of seems like a political name to disparage the act. So where do you want to start with all of this? I think most people don't even know what it is. And you're sitting here with two women with MSWs, and we still don't have, I don't think, a real grasp of what the Affordable Care Act is.
Yes, and that's pretty common. That it seems like it's a mystery more than than anything else to most people. And, Obamacare, President Obama uses the name. I was hesitant to use it, but he does. And the people outside of America, they love the name Obamacare and how much the Americans, are getting their healthcare system improved by it. So it's not a derogatory name. And the reason we use it is because everybody does relate to it. But the Affordable Care Act, ACA, is the proper legislative name. Either way, it's still pretty unknown. It's creating a lot more discomfort for people. I think the biggest thing about my perspective is that it's here, it's law. We like some of it, we don't like some of it. Everybody's going to disagree and agree about it, but the bottom line is the law, and now the real challenge is to adapt to it. And the reason I wrote The Familiar Physician is to really give doctors a sense there is hope here, but if we ignore it and pretend it's not going to happen, we're going to get crushed. Primary care or family doctors are a big part of the success of Obamacare, but it's going to make a lot of demands on the familiar physician, the known physician, the family doctor. And if we are not ready, it will crush us and make us extinct. And that's really, I think, the best place to start. And then we can backtrack to the Obamacare. But my main focus is what can doctors do now and prepare for what's coming and to prepare well.
Well, I think one of the things that you've said is that our healthcare system was in jeopardy way before Obamacare. And now, unless we do something and we react to it in a positive way, or we have some, as you're describing, that we'll have a perfect storm for disaster in healthcare. It's not that Obamacare has caused the disaster, but it's just that the disaster was waiting to happen. Our healthcare system was not good. We were in big trouble. And now, are you saying with Obamacare we have an opportunity to go forward in a positive way if we handle it correctly?
Yeah. Catherine, everything you said was correct. And so let's backtrack and pick that apart, unpack it a little bit. I mean, it's basically our healthcare system has been in crisis for, I'd say, a decade. Costs are paralyzing business and threatening personal income. Quality is inconsistent, and access to healthcare is poor. And we could break that down and go into details, but everybody's familiar with, how difficult it is to see your physician when you're sick, and how much it costs, and how much premiums have gone up. And so we don't really have to go into detail. People relate to that easily. And to blame this crisis on Obamacare is ludicrous, because we haven't even stepped into Obamacare yet. So it's changed a Category 3 storm that the doctors that's coming right down on primary care, the family doctors, into a Category 5. Obamacare has intensified the storm and sped up the speed with which it will arrive, or how fast it's bearing down on us. But the storm was coming at us. What Obamacare has done is brought us to the crossroads. Now, the reason I wrote The Familiar Physician is to doctors, really hoping your listeners will give a copy to their doctor, because a familiar physician, a doctor who knows you and you know and trust, is the most important thing to a person to have when they're sick. But it's also the most important entity in medicine. It's the most powerful entity, both in producing quality and decreasing cost. That sounds, a little bit crazy in the day when technology and these enormous facilities we have, the pharmaceutical discoveries we've made in the last 20 years that are making people live longer. But it's still a physician who knows you is your best chance of getting the care you need and making that care cost effective. So if we do lose our family doctors, the culture is going to lose something they don't want, but also lose the very mechanism that's going to make Obamacare succeed. But family doctors have to get ready. If we ignore it and think we can keep doing things the way we always have, we're going to get crushed by this Category 5 storm that's bearing down on us now, and that will arrive next year in very real terms. And
so what are the terms? I just want to stop you there. What are the terms? What is going to be the role in Obamacare for family care physicians?
Okay, then let's back up. The storm that was coming, that Obamacare has intensified, is the aging baby boomers. We have 40 million people over 65. In 10 or 15 years, we'll have 80 million. You have a third of the physician force retiring in the next 5 to 10 years, and you don't have med students in the pipeline to replace them. Now you add to that the 30 or 40 million people who will be getting access to primary care, to family doctors and general internists and pediatricians. Starting January the 1st, this insurance is going to be being used by this 30 or 40 million people. So that's what's coming. Now, why is it so important to family doctors? And by family doctors, I'm basically speaking of primary care, but people relate to who a family doctor is. That's the easiest term to help people understand what we're talking about. But now, instead of going to the emergency room or urgent care centers, these people, plus all the people right now who have insurance and are going to be accessing family doctors in primary care. The Obamacare is basically a mandate for robust primary care, to see these patients, to see them in a cost-effective way, and to see them in a timely manner. We're having a hard time doing that today. I mean, your listeners have gotten used to long waits, can't see a doctor for several days after they've called, and very unreasonable cost. All that's going to get worse unless primary care transforms. Everything we hate about our health care right now is going to get worse. And it's basically up to the family doctors to transform and get ready. It's much like Ford in 2008. They got thrown the ball, and they ran with it, and they fixed it. And now that's history. Ford has really, endeared themselves to America because they fixed the crisis they were in 2008.
So are you saying, Dr. Anderson, that we need, number one, more family care practitioners, and the potential is we may have less, and that they have to change the primary care physicians? If they use your model that I've been reading about, they have to actually change the way they deliver health care within their practices, because isn't that what you've done in terms of utilizing nurses and other health care practitioners? So the whole structure has to change if they're going to be able to address the numbers of people that are going to come into their offices?
That's exactly right, Catherine. We've got to expand our capacity and capability. And this means a transformation inside the office. Now, I would want to say that companies like IBM is the one that's led the charge, and they started in 2005, and 1,000 corporations and organizations have joined them, and they joined them within months. And the mission was to fix primary care. And they didn't even know Obamacare was coming at that time, but they saw this hurricane forming. And so they set out in 2005, and basically they've reorganized all of the upper levels of medicine, and in some senses they set the table for family doctors to come to sit down at the table to deliver better care. What IBM and their doctor leaders, Dr. Grundy and Dr. Sepulveda, have done is actually set the table for us at the grassroots level to come in and transform, to sit down at this table. Without their work, our work of sitting down wouldn't really be possible. What I'm asking doctors to do is to transform. My practice was a shipwreck in 2003, and then it's either quit or transform. I was desperate. I hated medicine. I couldn't see my patients. I couldn't give the quality they needed. I didn't have the communication back and forth that they needed. So I decided to try this new model, and it's as different as going from the house call to the traditional visit that we went to in the 1930s and 1940s. The house call had been our delivery model for 200 years. But we had to let go of it because when modern medicine came on the scene in the 1930s and 1940s, the house call was too cumbersome and inefficient. I'm saying that now we need to make that kind of transformation in primary care. Your family doctor has to transform the way they see patients, or they're going to get crushed. We're not doing it as just a nice thing to do. This storm is real, and it will crush the primary care system if the doctors don't transform. And I'm appealing to your listeners, get a copy of the book, read it, and give it to your doctor, because doctors don't have time to read and to study this kind of transformation. So they need a patient that they know and trust to come in and say, I don't want you to disappear. I don't want your practice to become extinct or inaccessible. But
so we're talking about the family team care model. This
Correct.
is your model. I want to be real specific about, telling us exactly what it is. I mean, you're talking about sharing this with the physicians who are already out there practicing. But what about the medical schools? I mean, you have to take these young medical students, don't you? The ones who you want to entice into family care. They have to know what it is, maybe understand this model, and entice may be the word. And just another piece. Don't you, if it's a primary care, that means this physician is primary in your healthcare team, and yet they earn the least amount of money in the whole team. I mean, so doesn't that have to be turned around as well?
Well,
reimbursement?
Under my model, I was able to see 40 to 80% more patients in a day. So my numbers went up from the low 20s to the mid 30s a day. That supplied a tremendous increase in the finances to pay for the staff and all the things I needed to have a robust primary care office. But primary care is the best discipline in medicine. It's the only place you can build relationships of 20 or 30 years. We all knew when we went into primary care we weren't going to make as much, but we went into it to have these kind of relationships. With the breakdown of our healthcare system, and today primary care offices across the country are understaffed and processes are inefficient and outdated. So doctors, because of being understaffed, they're spending 50% of their time doing non-physician work. It's administrative, it's bureaucratic responsibilities, and computer. And every patient, they know what it's like to go in a room and the doctor spends more time on the computer than they do talking to the patient. Now, and when I train my nurses to the top of their license to get help inside the exam room, I could focus on patients. I didn't have to mess with the computer. I could give my patients more time and attention. I built the best doctor-patient relationships I'd ever had.
Well, could you walk us through that? I'm a patient. Okay. I walk into your office. I have, a series of, give us a diagnosis of something. What happens in your office that's going to be that's different than, what traditionally has been happening in a primary care physician's office?
Very, very good question. It sounds like common sense, but it's a transformation that's huge, and doctors are very resistant to it because it's as big a change as leaving the house call to what we presently have. But when you come into my office, we give patients a half an hour visit. But the first 15 are with my nurse or medical assistant. I taught them to collect all your medical information about you, all the medical data that I need to know about you to proceed to make the appropriate diagnosis and develop the best treatment plan. That, for me to collect that data and to put it in the electronic medical record would take 20 minutes because patients now have 5 chronic diseases and several symptoms and 15 medications. So it takes a long time. We didn't know if we could, but our nurses and our medical assistants learned how to do this better than I could because they had time. So when you come to the office, you're brought back to a room, and a nurse collects all your information, the drugs, your symptoms, details about your symptoms, and information about any diseases you present with. And then when that's finished, I come into the room, and the nurse or medical assistant presents your information to me verbally in front of you. Now, the number one need of patients is to be heard. And when I'm typing on the computer, they don't have the slightest idea what I've heard or didn't hear. But when the nurse or medical assistant presents this information that they've just given them to me verbally, they're amazed. Number one, they know they're listened to. They see how well organized it is, and they see how complete it is. And they always respond, "Man, that was good," or "Wow, you got it," or "That I've never seen it done like this," or "Boy, that was so complete. Can my husband come here?" But they knew we heard them. We gave them adequate time, because that half-an-hour visit is one continual process, and so they don't break it down with Dr. Anderson came in for the last 15 minutes. They see that they got a half an hour of attention, and that half-hour attention is very valuable to me, because now I can get all the data. And I'll tell you, when I'm in that room 15 or 20 minutes by myself, I have to cut corners. But now with this visit and training my nurses and medical assistants, we don't cut corners anymore. And then after that data is presented to me, I'll verify, or the patient will hear it and change it if they think something's wrong. I'll ask any other questions necessary. My nurse, my medical assistant, stays in the room, changes or adds to the chart as necessary. And then when that's finished, I'll proceed and do the necessary physical exam and develop the diagnosis and treatment plan.
Dr. Anderson, as a social worker, I think one of the other things, this is from perhaps an emotional standpoint, and Alyssa, you probably, I'm assuming you'll agree with me. You go to the doctor, you're anxious, you're concerned, and if you just meet the doctor head on, sometimes it's very difficult even to remember the answers to the questions he or she is asking you. But if you have time and you've talked to the nurse already, it helps to kind of alleviate some of your fears. You calm down. By the time you get to the doctor, you may have more to add to it. So the whole process is a much more relaxing, I think, and efficient way of doing it. But I have another question. What about this? Because a friend of mine went to see a physician, and it wasn't a primary care physician. It was a specialist. But he actually filled out a form online answering all kind of the basic kinds of questions, so that when he went into the office, he didn't have to sit there and write out all the answers to some of the history of whatever his illness was. And that was kind of, I think that added an efficient piece to the visit.
And that's being tried a lot of places and been around a long time, whether it was a hard copy form you filled out and mailed back versus something that was connected to the internet. The problem is, so much of the information received is directly from the patient like that, and not specific guided questions from the nurse's side or the physician's side, gives us a lot more information that might not be necessary, might not be relevant to that situation. And so that works okay. But when I train my nurses, healthcare is such a personal thing. People, never will let a computer replace a person, because healthcare, we are always going to be personal, and healthcare is one of the deepest part of our personal, identities. That it's a good start, but it would not replace a nurse or a physician asking those questions. The problem is a physician doesn't have time, because we don't have enough physicians. If we had plenty of physicians, you wouldn't need to consider this process, but we don't have enough, so that's why we have to expand our capabilities and capacity in primary care and your family doctor. But what your friend did has done a lot, but I found that personally it didn't help me, because it gave me so much extra information. I still spent a lot of time having to weed through that and pull out what was really relevant from my particular situation. A specialist might be able to do it better because they are more focused in the medical world than a primary care physician. But and I'll give you an example. The fact that I know a patient gives me the chance to give better quality and to not waste money on unnecessary tests. But it also is the number one thing a patient wants to have when they're sick, is a doctor they know and that knows them. And I'll tell you about Selma, 77 years old. She'd been seeing me for 25 years. She smoked 2 packs a day for 50 years. And she came in with an increased cough. And I did an X-ray, and it showed a cancer the size of an orange. And I did a CAT scan, and it showed an aneurysm behind her heart that was bigger than the cancer. So she had 2 terminal illnesses, and her lungs were worn out. I sent her to a specialist just to make sure that I wasn't missing anything, but I told Selma that we couldn't do anything. and she saw the specialist, and he wanted to do a biopsy. Now, when I talked to Selma, I told Selma, I said, if you were my mother, there's no way in this world I'd let anybody do a biopsy on you. It's not going to help you. It's not going to tell us anything we don't already know. And I do believe it's got a chance of doing you more harm than of doing you some significant harm. And she said, Peter, I agree with you, and I won't do it. So I called the surgeon just to give him a heads up, and he told me, Peter, I agree with you completely. But in that 10-minute conversation, because Selma trusted me and knew me, I saved Medicare probably $100,000 in 10 minutes, but I also gave Selma the best care she could have gotten because I knew Selma. I was the only person in the world that could have really walked her through that decision process. That's why we can't let the family doctors or the general internists who are the familiar physicians become extinct. We have to transform, but what's coming is very real. This is not this is going to be like Sandy or Katrina. It's going to wipe us out if we don't get ready. And the good news is there's transformation possible to get ready.
I think that's a great example. I'm glad you gave us that example. Maybe you can give us another one, because you're so, it kind of like is the example of approaching the problem both from the emotional side, helping the patient, caring for the patient, and they're relying on you because you know them well, but also saving in terms of health care costs. That could be probably multiplied hundreds of millions of dollars if we had that kind of a scenario that you just described.
Well,
what do you do, though, Dr. Anderson? Because things have changed in terms of how people work and live in the United States. Like, you talk about having a relationship with your primary care physician over the years, but many people now are move from job to job, they move from state to state, they move from city to city, so they can't always, they may not have a long-term relationship with their primary care physician.
And that's the reality of what we're living in. I agree with you. You can't have a long-term, but wherever you are, you should be able to see the same physician on a continuous basis when it's necessary. That's one reason we have to have electronic medical records. They're essential due to the transient nature of where we live. And you can transfer the good information, and patients have so much information that we have to have electronic medical records. But the physician cannot be the one that's inputting the data when we have a physician shortage. So now, and I agree with you about saving money. Truthfully, if we had people seeing doctors that they knew, it could save almost $1 trillion. We spend $2.5 trillion a year on health care. Number one cost of our economy is health care. And we could drop that down by 35%, which is unbelievable, but it's all within the realm. An example is patient sees me, it's $100. That's a lot of money. Same patient goes to the emergency room, it could be $2,000 to $3,000 of unnecessary expense. I had one patient went to the emergency room, and I've been seeing him for years. It was $12,000, and I've been seeing him for years for the same symptom. $12,000 wasted for nothing. Now, somebody had to earn that money. Every dollar of health care comes from business. So if we can drop the cost of health care, business will thrive again and people will have jobs. Now, I'll give you an example of access, how that makes a difference. We can take 20 patients a day who just call us that day. I can see up to 40 patients a day under this model. And remember, patient satisfaction is the very top. I was assistant clinical professor at 2 medical schools, and our qualities was the best I'd ever given under this model. But a patient calls us Monday morning, it's 11 a.m. I have 38 patients on the books, and my nurse comes a little bit frantic to me. Says, "Where are we going to put her?" I know she knew I wasn't going to send her to the emergency room. That's just, if it's our patient, we're going to see our patient. And Susan is having this terrible pain, and she has to come in. And oh, by the way, she had a baby 6 days ago. Now, I've been seeing Susan for 5 years, and she's got a baby 6 days ago. I said, bring her in right now. And she had an abscess. It took me 1 minute to fix it. She will never forget it because she got immediate relief. I will never forget it because that's what I went to medical school to do, to fix problems when they needed to be fixed, not to send them somewhere else. I probably got paid more for Susan than any other patient I saw that day because it was a pretty big abscess. But if Susan had gone to the emergency room, that probably would have been a $3,000 bill. And she would have never forgot it because she would have sat at the emergency room for a couple hours and having a baby 6 days earlier. That's what robust primary care can do. It can save money, give patients the best care, and it gives me the pleasure of being a doctor again.
Yeah, you know, as social workers, one of the things that we do is we have, in order to help people in terms of their mental health as opposed to physical health, is to establish a relationship with them. And, you know, you don't go from one social worker to the next, 1 week to the next if you're getting counseling. So, I mean, the same thing does apply, I think, to physical health as well. I mean, I was going to ask you, because you talk about in your model, you have nurses. The nurse does the initial asking, the questions of the patient. What about social workers? Do they play any role in this model or not?
Well, see, in our situation, you've got to have something that will economically be feasible. Now, if the big system and you're working with 10 doctors, you could pull in a social worker and be able to make it cost effective. When I'm working with just 2 or 3 other doctors, we couldn't make it feasible from a cost standpoint. But I want to go back to your point about relationship. See, we've forgotten that, but you just articulated in a wonderful way. A relationship is over half the ball game. If you have a relationship with a patient, they trust you, they receive, they're engaged to do what you want to be done, whether it's lose weight or decrease salt or come back in 3 months or take your medications. And when patients see somebody they don't know, at least half the time they could care less what they're told to do. But a relationship engages people. I love seeing people I know. It's the joy of being a primary care physician. It's the pleasure of being a family doctor. And I'll say it again, being a family doctor is the best discipline in medicine. But if we don't transform and get ready, we're going to get crushed.
Well, Alyssa, do you want to? She has a question to ask you, and then I want to answer that question.
What are the doctors currently, how are they feeling about all this with the Affordable Care Act? Are they stressed about it? Or they think it's a step in the right direction? What are doctors today feeling in regards to this?
Well, most of them, I would have to say, and I was this way before I studied it, are just ignoring it. I would say at least 95% of the doctors I talk to don't really have an idea what's coming in the magnitude, or leaving it up to someone else to figure it out. They're just going to keep practicing the way they've always practiced. And that's why I wrote the book, because if we don't change, we will get buried. But the doctors who studied it, I mean, it's a mixed bag. Some really like it, some don't. But it's definitely going to increase the volume to primary care. So the primary care physicians are the ones who are going to get affected the most. But really, to answer your question, I would say most physicians are ignoring it.
Oh, okay.
So where do you find the most resistance, given that you said 95% of the physicians are ignoring it, thinking, well, it's not going to go away, they're just going to keep on doing what they do? Is it the specialists who are ignoring it, or is it the primary care physicians who are ignoring it? Who's ignoring it?
In my experience, they both are. Remember, primary care is on the verge of collapse today before we have Obamacare. Doctors don't have time. I was working 12 to 13 hours a day before I switched to this model. This model allowed me to go back to an 8 or 10 hour a day. But the doctors, I've met 3 doctors who were suicidal from just their work situation. It had nothing to do with anything beside work. But it's not an overstatement to say primary care, family doctors, general internists are on the edge of collapse. So they've learned, well, all I'm going to do is focus on my practice. I'm sort of drowning. I can't look at and try to figure out something else. I just hope somebody else figures it out for me. That is the predominant opinion, and that's both specialist and primary care, even though I would say primary care is a discipline that's really in trouble. And they're the ones that we have to bring up to speed to get ready, because a hurricane is coming.
What about the difference in physicians? And because, I mean, you're exposed to all of the most of these physicians. Is there a difference between the younger ones who are just coming out of medical school and the older ones or the baby boomer physicians? Are they on the same page or on different pages?
And that's a great question. A third of the physicians are over 55. We're the baby boomers. So you've got a lot of doctors who are close enough to retirement. They say, I can ignore it. I'll just grit my teeth and hold on until I retire. And a survey done last year showed that 60% of physicians would quit today if they had the money to. 60% would quit today. But the younger ones, the medical schools are slow to change. We've had significant discussions with several medical schools, but there's a lot of decision makers involved when you get into medical schools. Whenever I see, taught medical students, younger doctors in this model, I look him square in the eye, or she, and I say, you're crazy if you practice medicine under this old model. If you don't transform and learn this new methodology, you're stupid. You're absolutely crazy to stick to the past. It's like sticking to the house call. You can't give as good a care with the house call. You can't see as many patients. You can't focus. It's too inefficient. It's too cumbersome. And with the right labs and so forth in the office, you can make a huge difference.
Yeah, well, I think your description, I like that, where, it's like there was the industrial revolution changed everything, and then so did the internet changed everything, and so I guess that's the comparison. Yes, we had home care, the doctor came to the house, that changed, and now we're at another point, as you say, where there's kind of a revolution in healthcare. This is my last question because we have to say goodbye, but we've been talking about the doctor and the responsibilities of the doctor. What are the responsibilities of the patient in terms of all of this? Because I think the patient has a lot of responsibility as well in terms of their health care, and not only the health care that they get from the medical system, but their own health. What can you respond to that?
Well, that's a wonderful call to action, and again, that's why I wrote the book. Because patients need to pick up the ball and say, I want a doctor that knows me. And we don't have to lose that. Now, that doctor-patient relationship, because of lack of access, patients have gone to emergency room and ERs. 40% of primary care is done outside of the primary care physician's office. But the patient should demand, I want to see a doctor that knows me. I'll get better care and it'll save me a ton of money. But that means your doctor's going to have to transform. So patients need to carry the message, I don't want to lose you. You know me, I know you, I trust you. I value you. I want to keep seeing you, and I want to see you when I'm sick. That's the message patients need to embrace, because if they see a doctor that knows them, they're going to be engaged in the treatment plan the doctor gives them much more than a stranger. None of us like going to a stranger when we're sick. None of us.
Well, that's good advice, and I think I have to take it because I've done the opposite, I have to admit. I don't know about you, Alyssa, but I'm a baby boomer. Alyssa is the Gen Y or Gen X, not sure. But I kind of gave up. I said, well, my primary care physician doesn't have time to see me. He or she doesn't know me. I haven't had any bad, any crises. But I think so. Okay, you don't know me. I don't know you. I'll just come, get my checkup, and that's it. And I've sort of given up in terms of establishing a relationship. So,
that's perfect. That's absolutely perfect, because that's what we got to get away from. You owe it to yourself to have a doctor that knows you, and don't accept anything less than that. That's the most powerful entity in medicine. It's more powerful than pharmaceuticals. It's more powerful than these huge buildings we see, and it's more powerful than technology that is just amazing.
Well, Dr. Peter Anderson, author of The Family Physician, founder of Family Team Care Model, thanks so much for being on our show this morning.
Catherine, it's a pleasure.
It was a real pleasure. Thank you. We're going to say goodbye.
Goodbye.
And we got a couple minutes left, and then we have our next DJ. I love our next DJ, actually.
It was really good. I mean, he helped. It's sort of, he spoke about what should be anyway. If you think about it, you should have a relationship with your doctor, and they shouldn't always be trying to prescribe something to you that you don't need. They really should take the time to sit down, get to know you, and really help guide you. I mean, sometimes my doctor before had told me things and I really didn't listen to her because I didn't feel like she knew me and knew what was right for me. She would tell me things that she told all her patients, and I said, that doesn't fit in my lifestyle. That's not something I need. You need to know your patient, just like social workers. We need to know our clients. They're not going to listen to us or take our advice for their treatment plan or buy into what we're saying if we don't have that relationship. And whether it's emotional health or physical health, it's the same thing. And I think doctors and social workers and both types of professions really need to work together in developing a treatment model for their patients that they'll buy into and want to participate in and follow.
It has to be in a context. And if you have somebody who doesn't know you and they're prescribing whatever it is, whether it's medication, if they don't see you in
something you're hesitant to take as it is.
Exactly. Or what your experiences have been in the past, or what your family situation is like. I mean, it's completely out of context, or what your mental health situation is like. And so it doesn't make sense to you. And then you do walk out of the doctor's office not really necessarily following the prescription. And
that time that he gives you, it's 30 minutes. I mean, how many times have you been into the doctors where you're rushed? You don't even get to ask all your questions because it's either their body language or they know they have an ex-patient, or the nurse is interrupting in the room saying somebody else needs you. It's sort of like you just want to leave. You've already been sitting in the waiting room for almost an hour.
And I'm angry usually after that because I've either had a call because I had another appointment that I couldn't get to. So by the time they're taking my blood pressure, it is soaring, and it's like, and
it's frustrating.
And it's frustrating.
You get frustrated, and you just want to leave, and you don't even want to stay anymore. So I think there needs to be some sort of change. He was right, the change in how it's delivered, because doctors need to change their approach, and that will also help cause patients to change how they listen to their doctors. And it's something that needs to be done because the price of healthcare is going up.
Yeah, it's skyrocketing. And so I guess he was very helpful because I think we honed in on, obviously that's his area of expertise. And I guess I didn't realize how important in terms of the Affordable Care Act, Obamacare, that the primary care physician was the cornerstone of it. Did you know that? Or you probably did.
I know they're trying to prevent the emergency room visits, because I know even working with some of my clients, they'd go to the emergency room for things that, a cold sore because they didn't know what it was.
Yeah.
Something that you could just talk to your doctor about, and they'll be
talk to me.
Yeah.
Call your girlfriend.
Yeah. Something that is so minor, and they just went to the emergency room, waited there, and spent so much money of health insurance money on something that didn't need to be. So I think having that relationship where they can go to a doctor and actually get in when they need to be seen, not 2 weeks from now, 3 weeks now, a month from now, it will really help save money.
Yeah, I agree. We're going to say goodbye because we have our next DJ, Lady Gaga. That's all I think of when I see we're sitting in the studio. You can't see her, but she looks like really cool with this kind of bow in her hair and the big glasses, and you look great. Yeah.
Okay.
You have to.
So my take on that was just quickly. That makes me very happy with my primary care physician, and makes me thankful that
you have him or her.
Yeah, well, him. And I haven't been able to find one. My primary care is still in Ithaca, and when I go, I do have to wait a long time in the waiting room, half an hour, but then I have an hour with the physician. They actually take a lot of time.
An hour?
Yes.
On that note, an hour. That's fantastic. Yes. Okay. Well, you definitely can establish a relationship in an hour. That's fantastic.
Yes.
Yeah, glad you shared that. All right. That's Luke, Alyssa, Catherine. And coming up next is
Zsa Couture.
Zsa Couture. Love it. You've been listening to The Social Workers, so you got to kind of change your hat here. I'm Catherine Zox, your social worker with a microphone, with Alyssa Lotmore and Luke Stein, WCDB FM, University of Albany. Hope you enjoyed the show, and have a great week, and we'll see you next Thursday.
WCDB Albany.
So you take the mouse and click over there, and then you can choose someone you want to call.
My niece. I click here.